Let's discuss about acute mesenteric ischemia. Acute mesenteric ischemia is typically due to sudden occlusion or non-occlusive obstruction of intestinal blood flow. It could be arterial or venous. Occlusive ischemia is most commonly due to embolic or thrombotic involvement of the superior mesenteric system. It may be artery or vein, segmental intestinal strangulation, or the volvulus. Emboli typically are due to a dislodged cardiac thrombus, example underlying atrial fibrillation that occludes the superior mesenteric artery. Superior mesenteric venous occlusion is typically due to conditions such as hypercoagulable states, portal hypertension, and abdominal infections. Non-occlusive ischemia is due to hypoperfusion, for example, low cardiac output leading to splanchnic hypoperfusion and vasoconstriction. Patient usually develops sudden onset of periumbilical abdominal pain with nausea and vomiting. Please remember the pain is often out of proportion to the examination findings. The initial abdominal examination is often normal, for example, soft, non-tender, and non-distended, without peritoneal signs like rebound tenderness, guarding. Uh, uh, so there are no peritoneal signs. Progression of small bowel ischemia to infarction leads to a grossly distended abdomen, absent bowel sounds, peritoneal signs, and blood in the stools. For example, positive fecal local blood test. As a result, diagnosis requires a high index of clinical suspicious, especially in elderly patients with risk factors, for example, atrial fibrillation, peripheral vascular disease. Marked leukocytosis, hemochromatosis, and elevated lactate results in metabolic acidosis are common. CT of the abdomen shows signs of small bowel ischemia, focal or segmental bowel wall thickening, intestinal pneumatosis with portal vein gas, dilated bowel, mesenteric stranding, and is helpful in excluding the other causes of the abdominal pain. However, the diagnosis is best established with CT angiogram. Talking about the treatment usually includes fluid resuscitation, correction of metabolic acidosis, broad spectrum antibiotics, nasogastric tube for decompression, and surgical consultation is often required. Thanks.